So today I am going to present a rare case of Vogt Koyonagi Harada Syndrome in a young female patient. My patient was a 21-year-old female who presented with sudden onset dimness of vision in both eyes for last 2 days, and her best corrected visual acuity was finger count 1 feet in both eyes, and dilated fundoscopy revealed disc edema along with extensive serous retinal detachment involving macula. Ocular symptoms were preceded by low-grade fever, headache and tinnitus. Usually VKH presents as bilateral panuveitis, but in our case the anterior segment was spared and the disease manifested as posterior uveitis. So upon OCT there were certain findings which are very much sensitive for diagnosis of VKH, like there was subretinal membranous septa, folds of RP, there were fluctuations of internal limiting membrane, hyperreflective dots. These are very specific findings. Then the patient was started IV methylprednisolone, that is pulse dose, for 3 days, and after 3 days he was converted to prednisolone 60 mg per day, and we also added one immune modulator, mycophenolate mofetil 1 gram BT. And the outcome was excellent. The patient presented with so much of exudative retinal detachment, but after 7 days you can see minimal amount of subretinal fluid is present in the right eye as well as in the left eye. So the patient was closely followed up every month for recurrence, and best corrected visual acuity was 6.6 maintained in both eyes, and every month we were tapering 10 mg corticosteroid, and now after 5 months of maintenance, when the patient is recurrent free, the patient is on lowest maintenance dose of 10 mg of oral corticosteroid and mycophenolate mofetil 1 gram BT. The patient is also counseled regarding family planning. So excellent visual recovery can be obtained by early initiation of systemic corticosteroids in VKH syndrome, and initiation of immune modulators like mycophenolate mofetil helps us in 3 ways. First, it helps us in reducing the corticosteroid dose. Second is systemic adverse effects, and third, the recurrence of exudative retinal detachment. Thank you.
Thank you, Dr. Soumyadip. Again, I would like to say, what investigations did you do to rule out tuberculosis, even if they have these 3 signs which you said, very important OCT 3 signs which you mentioned. Can you just repeat them, the 3 signs?
Yes.
Very important,
First is subretinal membranous septa, then fluctuations of internal limiting membrane and hyperreflective dots.
And?
Bacillary
layer detachment.
Yes.
These are very important points, but these are seen in tuberculosis also.
That's so why we have to rule out all type of infective causes which are causing serous retinal detachment, like any kind of tuberculosis. We did IGRA, we did chest x-ray, sputum A, Biman2 test, everything was done.
So before starting your high doses of IVMP, what we follow in our hospital, we give posterior subtenance. Because of seeing all this, we give posterior subtenance, triamcinolone 40 mg per ml we give, and we investigate for tuberculosis, and then only we start on IVMP, because it could be fatal in case we start IVMP with any tuberculosis.
Thank you.